Good evening, everyone, and welcome to the DeVos Medical Ethics Colloquy, entitled Triage and the Allocation of Scarce Resources. My name is Dr. Lola Koch, and I am the Acting Dean of the Kirchhoff College of Nursing here at Grand Valley State University. Our college is now the host for the biannual DeVos Medical Colloquy events. The topics covered in these important dialogues directly impact healthcare for all interprofessional providers. I am so pleased to be able to provide the platform to continue this prestigious event and to join in these discussions. More information about tonight's event, including information on claiming continuing education credits, can be found on our event welcome website. It's listed in the chat for you to take a look at, or you can go to the website as well. You will receive more detailed information about the continuing education credits via email within 48 hours of the event. Just to note that all participants this evening will be put on mute and during the program. If you have questions, please put them in the chat. And we have someone that will be monitoring, not the chat, the Q&A. We have someone monitoring that so that we can capture your questions for our speakers toward the end of the program. A special thanks to the organizing committee for their ongoing support and leadership of this DeVos Medical Ethics Colloquy. I'd also like to give special thanks to my Director of Communications and External Events, Shannon Dale, who's helping with this event this evening. And now I'd like to introduce one of the Colloquy committee members, Dr. Paul Farr, who's a retired medical physician, a community volunteer, and secretary of the DeVos Colloquy Advisory Board, who'd like to make some opening remarks. Dr. Farr.
Thank you, Lola. Thank you for the introduction. I want to welcome everybody to the 33rd semi-annual DeVos Medical Ethics Colloquy. If you look at this picture, Rich DeVos, who's seated, asked Dr. Luis Tomatis, who's standing, to organize a colloquy back in 2004. So our first colloquy occurred in March of 2005, but it's thanks to both of these wonderful men who unfortunately are now gone. They're both deceased, but their legacy lives on in many different ways. Thank you to the Colloquy Committee, especially Professor Jeff Burns, Dr. Lola Koch, and Dr. Jean Nagelkirk. Also, thank you to our principal sponsors, Spectrum Health and Grand Valley State University, and to our major sponsor, Mercy Health, St. Mary's. Dr. Marquet Ripa is our moderator tonight. She's is the Clinical Services Manager for Oncology in the Lax Cancer Center of Mercy Health, St. Mary's, where she's been for many years. I won't say exactly how many, but it's been quite a few. She got her nursing degree from the University of Detroit Mercy, and then went on to get a master's degree and a doctorate in bioethics and health policy from Loyola University. In addition to her management duties, she is co-chair of the St. Mary's Ethics Committee, facilitates clinical ethics consults. She publishes and presents both locally and nationally. So it's a great pleasure to have her as our moderator tonight. Marquet?
Well, thank you, Dr. Farr, and thank you, Lola. I am honored to be a moderator for tonight's colloquy, which promises to be thought-provoking as we all navigate this pandemic. We have two very distinguished physicians as our presenters tonight who will guide us in applying an ethical lens as we consider the topic of scarce resources. Please again submit your questions in the chat box, which we will address at the end of both presentations. Each presentation will last approximately 30 to 35 minutes, followed by time for questions and answers. I'm pleased to introduce to you Dr. Bernard Lowe, President of the Green Wall Foundation in New York, New York. Dr. Lowe is Professor Emeritus of Medicine and Director Emeritus of the Program in Medical Ethics at the University of California, San Francisco, and President Emeritus of the Green Wall Foundation. A member of the National Academy of Medicine, Dr. Lowe has chaired National Academy of Sciences, Engineering, and Medicine, committees on sharing clinical trial data, 2015, and conflicts of interest in medical research, education, and practice, 2009, and currently co-chairs the Committee on Neural Cell Transplant, Chimeras, and Organoids. Dr. Lowe serves on the California COVID-19 Vaccine Drafting Guidelines Work Group. He chairs the External Advisory Board of the Multi-Regional Clinical Trials Network and serves on the Medical Advisory Panel of Blue Cross Blue Shield and the Ethics Advisory Council for Takeda Pharmaceuticals. During the COVID-19 pandemic, Dr. Lowe has also written articles on addressing vaccine hesitancy among persons of color and on the allocation of ventilators, inpatient medications, and cardiopulmonary resuscitation. He is the author of Revolving Ethical Dilemmas, a guide for clinicians. And by the way, this book is recommended reading for those of us who have sat for the healthcare ethics certification. So thank you, Dr. Lowe. He continues to care for a panel of primary care internal medicine patients at UCSF. And the title of his presentation tonight will be Ethical and Policy Controversy regarding COVID vaccines. Dr. Scott Halprin is the John M. Eisenberg Professor of Medicine, Epidemiology, and Medical Ethics and Health Policy at the University of Pennsylvania, and a practicing intensive care doctor. He is the founding director of the Palliative and Advanced Illness Research Center, which generates evidence to advance policies and practices that improve the lives of all people affected by serious illness. His awards include the American Federation for Medical Research's Outstanding Investigator Award for the best scientist in any field under the age of 45, the Association of Clinical and Translational Sciences Distinguished Investigator Award, and the Arthur K. Asbury Outstanding Faculty Mentor Award. He is an elected member of the American Society of Clinical Investigation and the Association of American Physicians, and serves on the editorial boards of the Annals of Internal Medicine and the American Journal of Bioethics. His presentation title is Equitably Allocating Critical Care Resources During Crises. Dr. Lowe will start us off tonight. Dr. Lowe, I will give you a 5-minute warning toward the end of your presentation. And his presentation is titled Ethical and Policy Controversy Regarding COVID Vaccines.
Thank you very much, Dr. Ripa, Dr. Farr, and Dr. Koch. I just want to make sure that everybody can see my slides okay. I first want to say that I don't have any financial conflicts of interest to disclose. Let me try to look at the screen. There we go. In this session, I'd like to cover 3 broad topics. First, how does the ethics of clinical care differ from the ethics of public health? I'll present some background information on the risk of COVID, on attitudes people have towards vaccination. And finally, I'm going to analyze the ethical issues regarding vaccine incentives, mandates, and passports. So let me first start with the distinction between clinical care ethics and public health ethics.
Dr. Lowe, I'm sorry to interrupt you. Could you just tilt your camera up a little bit? We lost sight of you there.
Okay, is that better?
Perfect, thank you.
Okay. So when we go to the doctor, we expect the doctor to base decisions on what is best for us as an individual patient and on our patient preferences. Competent, informed patients may refuse any recommended test or treatment. And this is based on the patient's liberty and freedom from unwanted touching or bodily invasion. Public health ethics differs. The next slide shows that Hurricane Katrina in 2005 put New Orleans underwater and cut off this hospital from all power. So they had no cell phones, no electricity, and were cut off until private boats were able to come to their aid. They had to evacuate patients to the roof of the hospital. After this chaotic response maybe non-response to a disaster, each state was to develop emergency plans and crisis standards of care. These crisis standards of care limit the liberty of individual patients and physicians to make decisions in order to foster the common good. Doctors still have an ethical duty to provide the best care possible under the circumstances. And I think Dr. Halpin's going to talk more about how that plays out in the critical care setting. Currently, crisis standards of care are in force in Idaho, Alaska, and Texas. After a declaration by the governor, the crisis standards require the following steps. First, the state tries to get more resources to stretch the resources available so that crisis standards don't have to come into effect. But if there just aren't enough resources that, to go around for all patients, it is permissible to modify the standard of clinical care if it's impossible to provide ordinary conventional care to all patients who need it. In particular,
Dr. Lowe, would you reset your camera, please?
Scarce resources may be withheld from certain patients to care for others with a significantly greater likelihood of survival. Now, under crisis standards of care, it is possible that some patients may die who would otherwise survive under ordinary circumstances. Now, there are other situations in which the limits of individual persons are restricted. Drunk driving is a significant problem in the US. Drunk drivers cause about 10,000 deaths in the United States every year. And we place limits on the freedom of individuals to drive while drunk because of the risk this poses to other drivers, pedestrians, and bystanders. Drunk driving is illegal in all states. And as a condition of obtaining a driver's license, people agree to submit to an alcohol test if suspected. And the next slide shows a picture of someone undergoing a field alcohol test. Crisis standards may also apply in infectious disease pandemics. Let's go back to 1902 when there was a smallpox epidemic in Massachusetts. The city of Cambridge, just outside Boston, passed a measure to require vaccination or revaccination of all adults. Now, please note this did not require people to be forcefully vaccinated. Mr. Jacobson, a minister, refused vaccination and appealed the fine he was charged. This case went all the way up to the US Supreme Court, who handed down an important ruling in 1905. The court acknowledged, quote, the inherent right of every free man to care for his own body and health in such a way as to him sees best. So that's individual liberty. But in this particular case, the court ruled that the rights of the individual in respect to his liberty may at times, under the pressure of great dangers, be subjected to such restraint to be enforced by reasonable regulations as the safety of the general public may demand. Now, I highlighted on this slide great dangers and reasonable, because these are terms that require interpretation. And people, thoughtful people, may disagree on whether a particular danger is great or not, or whether a regulation is reasonable or not. And in our form of government, it's the courts that ultimately decide those questions. Now, on the next slide, the ruling upheld mandatory vaccination during the smallpox epidemic. Court said, real liberty for all could not exist under the operation of a principle which recognizes the right of each individual person to use his own, whether in respect to his person or his property, regardless of the injury that may be done for others. Now, I think it's fair to ask, would this case be decided differently today? And we may actually see a ruling on this sometime in the future. First, today, the courts give more deference to religious freedom when the government acts. And It's required that there be reasonable accommodation for religious beliefs, and we'll see how this plays out with various public health proposals. The courts now apply stricter scrutiny if a government restricts fundamental rights, and liberty is certainly a fundamental right. Now, I would argue that the facts of the case should be crucial, and such questions as the following would be important, I think. First, under the current circumstances of the case, can hospitals and intensive care units provide care for patients who need it? And second, is the trend in the number of patients needing hospitalization and critical care going up or going down? So this case really summarizes the tension in any society between individual liberty and the common good of the community. In general, we think that the individual should not be allowed to harm others who live in the community, and that there may be limits on individual liberty when the liberty or life of others is threatened. And there are many examples of this. For example, no one is permitted in the name of their individual freedom to drive a car on the sidewalk or to run through red lights, and we accept these restrictions. Now, throughout this talk, I'm going to keep coming back to a framework for public health interventions. And let me go through the 6 questions here. First, is the threat to public health serious? Second, is the intervention effective and the risks of the public health intervention acceptable? Third, is the intervention the least restrictive alternative for achieving a public health goal? 4, will patients whose liberty is restricted have due process? 5th, will the intervention be implemented equitably? And 6th, has the policy process been transparent or fair? I've highlighted in red the issues that we'll particularly talk about today. If the answers to all these questions is yes, there's a strong justification for the public health intervention. But today, there are sharp disagreements in the US about how to answer these questions with regard to various COVID public health measures. Now, despite such deep disagreements, I think a framework helps to clarify the nature of the disagreements, and it may help suggest where common ground might be found. And after all, in a society, we have to find a common ground for laws, regulations, and policies. Now, there are very great challenges today to public health interventions. I'm just going to summarize quickly some of them. First, there are people who deny that COVID presents a serious public health risk. Some may believe that COVID is a hoax, that governments and hospitals are lying when they talk about the large number of cases. Others may reject all public health statistics and evidence. The second challenge is that some people object to government authority or to public health interventions in particular. And third, some people dismiss concerns about equity, and I think Dr. Halpern is going to talk some about the importance of equity. Let me next shift to giving some background on COVID-19. 4 quick topics. First, who is at highest risk for COVID? Second, which patients intend to get the COVID vaccine or not? Third, what outreach to unvaccinated persons has been attempted? And 4th, what education and persuasion incentives have been attempted regarding COVID vaccines? Let me first start by talking about the risk of COVID. As of this morning at 11 o'clock, there were over 42,839,000 cases of COVID in the US since February 2020. The total number of COVID deaths in the US since the beginning of the pandemic was 687,000, and these numbers continue to go up. To put that number, 687,000, in perspective, in any year, or the number of annual heart disease deaths is 690,000, and the annual number of cancer deaths is 598,000. So the total COVID deaths outpaced the annual mortality from heart disease and cancer are two biggest killers. Now, numbers may not give the whole flavor of what's going on. One impact of COVID, sorry about the typo, is delays in surgery in areas with high COVID hospitalizations. Elective surgeries have already been canceled, and now hospitals are canceling non-elective surgeries. Now, these non-elective surgeries are actually sometimes very urgent. So, for example, what's being postponed now is surgery or bone marrow transplants for cancer. And that delay may jeopardize a cancer patient's chance of being cured. Other surgeries now being canceled are open heart surgery to repair a leaky heart valve that causes shortness of breath, or pacemaker insertion, which would prevent repeated episodes of passing out. Skip this next slide. Let me now talk for a few minutes about who is at highest risk for COVID. The risk for COVID increases sharply with age. Compared to young adults, 18 to 29, the risk of death increases age 15 above, and it keeps climbing with greater age, so that people over 75 are 220 times more likely to die of COVID than young people, and people over 85 are 570 times more likely to die. There are racial ethnic disparities in COVID. So compared to whites, Blacks, Hispanics, and Native Americans have a higher risk of being hospitalized and a higher risk of dying because of COVID. Now, there's some social science evidence about what people say about whether they plan to get COVID vaccines or not. So first, vaccine intentions have changed over time. Over time, the percentage of patients vaccinated has increased, and currently 75% of Americans over age 12 have received one shot, and 65% are fully vaccinated. But a significant, substantial minority of people remain opposed. 7% say they would get vaccinated only if required. 13% say they would definitely not get vaccinated. And these percentages have not changed since these polls were started in February of this year. Now, COVID vaccination rates also vary according to people's political beliefs and leanings. So the red side shows the vaccination rate in counties that voted for Trump in the 2020 elections. And the blue slide shows the COVID vaccination rates in counties that voted for Biden. And as you can see, the vaccination rate in counties that voted Democratic are greater, significantly greater than counties that voted Republican. Now, concerns about the vaccines are widespread, and they break down a little bit according to race and ethnicity. So people of all ethnic and racial backgrounds have concerns about serious side effects, concerns about missing work if they have significant side effects. They're concerned about whether COVID vaccines might impact their fertility, and they're concerned they can't get the vaccine from a place they trust. These concerns need to be addressed in order to persuade people who aren't yet vaccinated to be vaccinated. If we don't address the concerns, I think it's unlikely that people would be persuaded. Now, there have been many attempts to reach out to people who are unvaccinated. I'm just going to show some slides quickly to illustrate that. Those of you who are marketing students or have worked in marketing are familiar with several fundamentals. First, you segment into target audiences. You have to understand the perspective of each separate target audience. And you want to shape your messages to specific audiences. You don't regard the population as a homogeneous whole. This is Coach Nick Saban of the Alabama football team. They've won the national championship several times recently. And he recorded a public service ad supporting vaccines directed at Alabama Crimson Tide fans. There's also been a move to go to where people are, where they live. Washington, D.C. launched a door-to-door effort to reach out to senior citizens who hadn't been vaccinated. This particular effort wasn't to vaccinate people, it was really to provide them information, and if they were interested in getting vaccinated, to help them make an appointment. This was a time when it was hard to make an appointment. In rural counties, other innovative outreach has been carried out. This county in Delaware repurposed its schoolmobile, its mobile library, to become a COVID vaccination van going to rural areas. Many people go to church regularly on Sunday. It's a place they know how to get to. It's a place they trust and feel comfortable. And so a number of churches have used their Sundays as to set up vaccination sites. So I want to point out the gentleman administering this shot is a firefighter in Florida. And firefighters are trusted really pretty highly among all segments of the population. And finally, for people who can't leave their homes because of disability or serious illness, if they want to be vaccinated, many jurisdictions are now sending public health workers out to their homes to vaccinate them there. So I just listed options for increasing vaccination, and we'll talk about the order of the list in a minute. So first is education, outreach, persuasion by trusted messengers that we've talked about. I'm next going to talk about incentives and penalties to try and increase vaccination rates. Then mandates for vaccination to engage in specific activities or to enter specific locations. I just want to say, though we call them mandates, they may not really be mandates in the sense that people may still have often still have a choice, although it may be a very unattractive one. Now, going down this list from outreach and education down to mandates, we're going from less restrictive to more restrictive public health measures. Education, outreach, education, and persuasion are consistent with freedom of speech, which is really a bedrock principle in the US, constitutionally protected. And incentives, as we'll see, I think, do not really restrict liberty, but mandates are more liberty restricting, and therefore there's a higher need for justification as we go down that list. So again, just to remind ourselves of our public health framework, is the threat serious? Is the intervention effective? Are the risks acceptable? Is the intervention the least restrictive alternative? So vaccine incentives, these may take a number of forms. Many states have instituted cash payments, usually $100, $200. Some states have instituted large lotteries, lotteries for large prizes up to $1 million in some circumstances. And other incentives are that if you're vaccinated, you can avoid requirements for frequent, regular COVID testing. Now, there are some current concerns about vaccine mandates. First, it makes sense that people will be motivated by financial incentives. In the healthcare arena, in employer wellness programs, incentives have been shown to increase healthy behaviors, at least in the short term. And Dr. Halpern's done some of this important research. It's really unclear at the current time, I think, whether COVID vaccine incentives have been effective. And there have been at least some theoretical concerns raised about adverse consequences associated with vaccine incentives. The argument runs that people may infer risk from being offered payments for vaccination. Thought is that If it were completely safe, why would they offering payments to me? There also have been concerns raised that people may expect an incentive for future vaccines or boosters. And now that it looks like boosters are very likely for many of us, are we going to have to give incentives for people to get boosters? Negative incentives might be framed as penalties for the unvaccinated. And penalties might be effective, but they may also be considered punitive and they could generate resistance. Some of the penalties for being unvaccinated include no sick leave if an unvaccinated person develops COVID, an insurance surcharge for unvaccinated employees for their health insurance. Delta Airlines, for example, put in place a $200 monthly surcharge on unvaccinated employees because that is how what they calculated the likely, the prospective increase in healthcare costs. Another penalty is that unvaccinated people may not enter sporting venues in San Francisco and New York, including basketball players on the NBA team. And it's a big issue with the Golden State Warriors now. Various leagues have said a team will forfeit a game if they cannot field a complete team because of COVID isolation and quarantine. And I just want to say, I think at this point it's unknown whether these penalties are effective or not. Now, the next thing in this list of increasingly invasive, liberty-limiting public health interventions are vaccine mandates. And these are to do specific activities or to access specific locations. So one kind of vaccine mandates has been in place for many years. Foreign countries may decide to restrict entrance to people coming into the country who don't have certain vaccines. And this is the case in some countries. In fact, today also, if you want to visit the state of Hawaii, you need to be vaccinated or have a very recent negative COVID test. A number of colleges and universities are requiring vaccines, COVID vaccines, to live on campus housing, to attend in-person classes, or just to register for classes. And some locations require proof of vaccination to enter restaurants, bars, and clubs. Furthermore, employers are increasingly requiring their workers to be vaccinated for COVID. The most discussion has centered around healthcare providers. I think one way to frame that is to ask you to think, suppose you had a grandparent who was a patient and at risk because he or she was undergoing cancer chemotherapy and was at risk even though they had their series of vaccines. How would you feel as a loving family member if doctors and nurses at the hospital where your grandparent received care were not vaccinated? Recently, active duty personnel in the US military were required to be vaccinated for COVID. And again, there's a long history of soldiers in the military being required to undergo vaccination for various things. More recently, federal employees and contractors will need to be vaccinated, and private businesses over employing more than 100 people will need their employees to be vaccinated. Now, one interesting legal point is that people whose job requires COVID vaccination and don't get vaccinated may not be eligible for unemployment benefits if they're terminated because of their non-vaccination decision. Now, when we think about vaccine mandates, I think it's important that we understand that there need to be exemptions and alternatives. I think that by and large, there should be reasonable accommodation of medical or religious exemptions. And I think this is going to be challenged. It's already being challenged in the courts, and we'll see how this plays out. Many policies of vaccine mandates actually will provide an alternative of regular, frequent COVID testing. And again, an individual who really doesn't want to be vaccinated does have a choice not to travel to that foreign country or to find another job or another employer. For example, in the healthcare field, there are nurses, doctors who don't want to be vaccinated, who are leaving their current positions and going to work in states that don't require vaccines and in fact have a ban on vaccine mandates. So let's apply our criteria, our framework to assessing vaccine mandates. First, is the threat serious? Well, all the clinical evidence we have is that the risk to unvaccinated persons is high for patients who are in healthcare settings who are immunocompromised, people with active cancer treatment, transplant recipients. Even if they're vaccinated and even if they get a booster, they're still going to be at higher risk. In addition, people who reside in congregate living arrangements, that includes college and university dormitories, seniors in nursing homes, and people in homeless shelters, they're at increased risk even if they're vaccinated because of the close proximity of others. Now, are vaccine mandates effective? That's a big question mark. There's been a backlash by the public and by workers in some occupations. If many essentials workers do not get vaccinated, it may be challenging to provide important services to society. So we talked about healthcare, police forces in some parts of the country, prison guards are saying we're not going to get vaccinated. In at least one state, the government has begun steps to mobilize the National Guard to provide personnel for hospitals to replace workers who decide not to be vaccinated. Now, are the risks of vaccine mandates acceptable? I think they are more acceptable if we accommodate medical and religious exemptions and offer alternatives. People who are concerned about government outreach may object strongly to vaccine mandates, particularly from the federal government. And several states have banned vaccine mandates for various situations. The laws vary from state to state. How about less restrictive alternatives? Well, I tried to present some slides on how outreach, education, persuasion, and incentives have been tried and haven't really gotten us to the vaccine level that would achieve herd immunity and blunt the Delta surge.
Dr. Lowe, 5 minutes, please.
Okay, I'll wrap up quickly. I'm going to talk quickly about vaccine passports. It's required for entrance to things like concerts, sporting events, restaurants, and bars. And they're digital passports that are available in some states. Now, ethically, vaccine passports are a tool to document vaccination status for a specific purpose. So they bring into play all the objections to vaccination for those purposes. But they also raise additional ethical concerns regarding privacy and the government role in setting up a passport app or website. So are vaccine passports effective? The existing ones have a lot of flaws. Are the privacy risks acceptable? The quick answer is we don't know. They're claimed to be protective of privacy, but they need to be tested by independent experts. You can't rely on the word of the developer. And they've been banned in several states because the thought is that they're not acceptable. Less restrictive alternatives. There are paper vaccine cards that we all got if we got vaccinated. They can be forged, they can be bought on the internet. And equity is a problem. If you don't have a cell phone, don't have internet access, not tech savvy, you're not going to be able to access a digital passport. So let me wrap up with this slide. The remaining challenges are, how do we address the deep disagreement over effectiveness, risk, and acceptability of public health interventions? I think two particular challenges is how to respond to claims that COVID is not a serious risk or that vaccines are unproven. My own view is that valid evidence needs to be considered, but it may not be definitive for policy purposes. There's deep disagreement over the scope of government in the US. How do we balance individual liberty with serious risk to others? And I think the challenge here is to think not just of our own liberty, but how our actions, our freedom may impact adversely on others. So let me stop there and thank you. And I look forward to the Q&A period.
Thank you, Dr. Lowe, for your fascinating presentation. Again, everyone, please submit your questions in the Q&A and we'll address all questions at the end of the presentation. Our next presentation is by Dr. Halperin, and his presentation is titled Equitable Allocation of Critical Care Resources During Crisis. Thank you, Dr. Halperin.
Thank you very much to the organizers of the colloquy. It's an honor to be with you today. It's particularly an honor to follow Dr. Lowe, from whom I've learned so much in the 16 years since we met. A real giant in the field and a wonderful mentor. If I'm sounding a little tired, it's because I just got off a busy 7 days in our medical intensive care unit, where the allocation of our services was front and center on many of our minds. We had literally 0 available beds in our 24-bed intensive care unit for 6 of the 7 days. This was not actually in large part due to the direct effects of COVID. Only 3 patients on my service were in the ICU with the manifestations of the coronavirus. But in fact, what we're seeing increasingly, and those of you in clinical roles, this will probably resonate for, are some of the after effects of COVID-induced restrictions on regular chronic disease management, causing many patients to present in later, more decompensated states than they would have prior to the pandemic. That said, I did yesterday lose a patient from COVID, a patient who was incredibly well educated, including a law degree, who made an informed choice not to get vaccinated. In his case, it was due to a putatively legitimate medical reason, given a chronic disease he was dealing with. And unfortunately, that choice didn't work out in his favor because, as I mentioned, he passed late yesterday. So with that as backlog, or background, I should say, I'm going to dive right in. I don't have any conflicts germane to this talk per se, but I do like to list the sponsors of the work that I do, as well as many of the health systems that we partner with around the country in doing our scholarship. And I'm going to begin, and I don't usually do this, but I would like to actually begin with the bottom line, or the bottom lines, I should say. I will repeat this towards the end, but I'd like to highlight 5 general points in the next half hour. The first is that absent pandemics, we have a glut of critical care in this country, way more than we need. That's inefficient and it's inordinately costly. And yet, despite that system level glut, dramatic variations exist across hospitals and within hospitals over time, causing what we refer to as dynamic capacity strain. As a result, there are local needs to allocate critical care, and those needs are normal. They exist absent pandemics. What COVID has really done is made the need to allocate critical care much more obvious, common, and consequential. Consequential, of course, in terms of the direct implications of that allocation. There are a variety of well-intended proposals to govern the allocation that have been put forth. I will go through some. A virtue of all of them is that they seek to guide allocation in what I would call a top-down fashion, which is to say that we're not charging individual bedside clinicians with deciding who gets the vent or who does not. Instead, we're coming up with hospital or health system or even state level policies that consider those systems as a whole and implement rules for the system as a whole. Taking the bedside clinician out of the decision-making equation, as Dr. Lowe highlighted, that could be considered a restriction on the individual clinician's autonomy, but it's intended to remove any biases that might exist with that clinician. And unfortunately, although all of these proposals are very well intended, as you'll see, there are some major ethical problems with all of the ones I'm aware of. So that's a bummer, but I'd like to conclude the talk with a more positive note that while as we search for equitable models and mourn the unprecedented tolls of the pandemic, I think we can actually find some solace and some lessons learned from the pandemic that will spur us to a greater future. All right, so I told you that the US has a glut in critical care. These data from my close colleague Hannah Wunsch are old, and the numbers are no longer accurate. But the overall story that these data tell remains true today. Across developed countries, you can see that there's a roughly linear relationship between the number of hospital beds that a given country has deemed appropriate for the size of its population and the number of ICU beds on the y-axis that those countries have deemed appropriate. Except for in the US, where, as you can see, a much greater proportion of all hospital beds in the US are ICU beds. In fact, and this highlights how old these data are, the best data we have suggests that the US now has 38 intensive care unit beds per 100,000 population. That number is not static across states or even across counties within states, but that does reflect the nation as a whole. And that's a high number. Perhaps as a result of that, these data that Dr. Wunsch and I produced many years ago track on an hourly basis the number of beds, intensive care unit beds that were full from the 3-year period from the beginning of 2005 to the end of 2007. And each tiny little vertical line here represents an hour over that 3-year period. And what you can see is that on average, about 2/3 of ICU beds are full and that about 1/3 of ICU beds are occupied by a patient on a ventilator. Those numbers are fairly low and reflect the existing capacity in the system in normal times, and the fact that as a nation, we have a large number of ICU beds per capita. Furthermore, there is a clear, if you build it, they will come phenomenon. So for fans of the movie Field of Dreams, this could not possibly be more true. This graph from my mentee, Dr. Weissman, shows that if you plot the 50 states, the number of beds they have leads to the number of ICU admissions they have. So if we were to build more beds, we would have more ICU admissions. Would that be a good thing? Well, let's wait to pass judgment on that question for just a moment. I'd like to talk about the financial implications of this supply of critical care in the United States. So critical care in the US costs about $100 billion a year. That's 3.8% of all national healthcare spending, and about 2/3 of 1% of the entire nation's gross domestic product. If you thought that those numbers were hard to conceptualize, imagine that US critical care was itself a country. If it were, it would have a larger economy than Morocco, Slovakia, and Ecuador. That's big. That's a lot of money. And yet, despite these dramatic expenditures on critical care in the US, even during non-pandemic times, scarcity rises variably across places. To orient you to this figure, each vertical line is one of 157 intensive care units across the country. And what we've done on the y-axis is plot the proportion of hours in which a certain number of beds were open, unoccupied, but there was staff available if patients wished to be admitted, were available to fill them. So on the left-hand side, you can see that about 20% of ICUs have 4 or more beds available 100% of the time. And on the far right of the slide, you can see that a small number of ICUs have 0 or 1 bed available almost all of the time. That's a big difference. I happen to work in an ICU that would be on the right-hand side of this graph, but not all ICUs are like that. And that causes local or regional scarcity on a regular basis, absent pandemics, and so triage decisions need to be made. How good are we at making triage decisions? Well, the first evidence of this arose in this classic article that was in the New England Journal in 1983, and it described a single ICU's experience with a nurse shortage. This ICU had 18 critical care nurses during usual times, but for reasons that aren't worth getting into, that supply went down to 8. And so they had to close a large proportion of their beds. They typically had 18 beds open, and they had to close it down to no more than 10, sometimes as few as 8. So what happened? Well, the days that there was at least 1 bed available in this particular ICU shrunk considerably. It used to be almost all the time, 95% of days, and it went down to 55% of days that there was at least 1 bed available. There were fewer admissions for what we might consider to be discretionary choices to admit patients to ICU, reasons for monitoring and observation. In addition, the length of stay among those who did get admitted also went down, probably because there was increased demand to turn those patients over quickly. There were also more patients with what we might consider, maybe legitimate is the wrong term, but mandatory admissions to the ICU, those who were actively requiring life support. And one form of that is shown in the graph on the right, which I show you in part just to give everyone a chuckle of what graphs in the most prestigious medical journals looked like just 30 years, or actually close to 40 years ago now. Drawn with a pencil and a straight edge, I'm sure, you can see that as the number of ICU beds went up, the proportion of patients with chest pain who truly turned out to have myocardial infarction or heart attack went down dramatically. So more patients with more serious illness get admitted when beds are scarce. And yet, despite all of that, there were no changes before or after the nursing shortage in the overall mortality rate in that hospital. That's one hospital from a long time ago with a before-after study design. So lots of things that you might question here. But here's another study more recently from 157 ICUs across the US and more than 200,000 patients. And here we find that depending on how busy the ICU is on the days, later days in patients' ICU stays, they get discharged from the ICU more quickly. So what you can see on the x-axis here is what we refer to as ICU turnover, the proportion of patients in an ICU who are newly admitted in the last 24 hours. And we plot the ICU length of stay of patients discharged as a function of that. So as more new patients are coming in, the patients who are already there get kicked out more quickly. And those effects are dramatically higher, meaning the negative sloping line is even steeper as the patients who are already in the ICU get sicker and sicker. And yet, despite that dramatic effect on how long we deem it appropriate to keep a patient in the intensive care unit, we don't really see any major effects. On the left, you can see that if we were to plot the 5th percentile of capacity strain against the 95th percentile, two real extreme conditions, you get a reduction of about 6.5 hours in the average length of stay in the ICU, from about 55 hours down to just shy of 49 hours. That has one consequence, which is patients are more likely to have to be readmitted to the ICU within the next 3 days, an increase of 1% in absolute terms. But there's absolutely no difference in the probability that those patients discharged from the ICU would die in the hospital, exactly 4 to 4.1%, no matter how busy the ICU was. And also no difference whatsoever in the probability that those patients would be discharged home to be relatively independent. Happens about 66% of the time, no matter how busy the ICU was. So these are dramatic variations in strain that yield essentially no consequences for patients, arguing that, again, during normal times, we do allocate care, but we do so efficiently. We do so in ways that do not harm individuals. Pandemics change all of that. Here's just one more example before we get to COVID. This is a paper from our group that was out last year showing that a new, more complex measure of capacity strain that considers issues across the hospital system, measures of how busy the emergency department is, how busy the wards are, how busy the ICUs are, shows that among patients with respiratory failure or sepsis who are in the emergency department, the odds that they would get admitted to the intensive care unit instead of the ward decrease dramatically the busier the hospital is. In orange, you can see that for patients with respiratory failure, in the lowest decile of hospital strain, 47% of those patients go to the intensive care unit. At the highest decile strain, that number is down to 13%. And similar, albeit perhaps less dramatic, changes for patients with sepsis. And at least in these hospitals, importantly, not only is that allocation efficient, it's done in ways that aren't harming patients, but it's done in ways that seem to be equitable. Another one of my mentees, Dr. Chris Chesley, who received the Health Equity Fellowship from the Maine Pulmonary and Critical Care Society, the American Thoracic Society, for this work, has shown in a paper that's forthcoming that the rates of decline in odds of being predicted or odds of being admitted to the intensive care unit are similar across racial and ethnic groups. Interestingly, Black patients were actually admitted to the intensive care unit more often across all deciles of strain after accounting for their severity of illness. And I'll come back to that in a moment as to why that might be. But the main finding here is that when beds get tight, at least these 27 hospitals do not seem to be restricting access preferentially by race or ethnicity. That's good. Things change under crisis standards of care. As Dr. Lowe mentioned, Idaho is one of 3 states to have an active crisis standard of care in place. And so we need to think differently about allocating, or perhaps not differently, but more consequentially. These are 2 pieces that came out at the beginning of the pandemic at roughly the same time, one in the New England Journal and one by Dr. Lowe and our mutual colleague, Dr. White at the University of Pittsburgh. And listed on the right are several ethical values and guiding principles that might be used to allocate ICU beds, ventilators, and services. And the ones that I would say both of these frameworks put the most weight on are shown here: save the most lives and save the most life years, which is to say that we want to maximize benefit, not only by minimizing the number of people who die in the short term, but also by minimizing the number of people who die over some intermediate period of time, say 5 years or so. Other relevant considerations might include, giving priority to those who are likely to make relevant contributions going forward, which is to say frontline workers, not specifically healthcare workers necessarily, but those in industries where they can't easily work from home. They need to be present in the grocery store or elsewhere at a variety of factories, or of course in healthcare settings. And that, at least as a tiebreaker, we might consider giving priority to persons who are younger. Those are relatively solidly agreed upon criteria among ethicists, but by far certainly not uniform views. There are some other issues to consider. If we were to allocate ventilators, for example, equitably, then that means not only do we need to decide who gets the last one, but we also need to decide if all of the ventilators are currently being used, who do we take off the ventilator and allow to die to make room for someone who might benefit more? And our colleague, Dr. Trug, described this as the toughest triage because that act of discontinuing mechanical ventilation is heart-wrenching to even consider, even if it's ethically appropriate. We also argued that the urge to build more beds and ventilators, which was one of our earliest responses to the pandemic, seemed to make sense, but actually didn't. It was never going to be the case that beds or ventilators were the scarcest of resources. It was always going to be the case that trained respiratory therapists, nurses, and clinicians were going to not be available to use a supply of beds and ventilators that was already bigger than our existing supply. So although that urge resonated, it gave people hope that they wouldn't be denied a breathing machine. It actually would have done almost nothing to stem the tolls of the pandemic. What does matter is how busy a system is. This is a really clever study where they built not the same measures of capacity strain that I was talking about in the prior studies, but what they called a COVID-specific surge index. And what they're showing here is during the early part of the early part of the pandemic, from March to May of 2020, you can see that as the hospitals got bigger, the odds that patients with COVID died would go up, but not a ton. Looking at the 50th to 75th percentile, really no difference compared to the less than 50th percentile. And even at the 99th percentile of the surge, compared to less than the 50th percentile, only about a 50% increase in the odds that patients would die. Now, that's not trivial, of course, but if you compare that to later in the pandemic, when overall mortality was actually down, and the reasons for that were the introduction of remdesivir and dexamethasone and other lessons learned in how to manage patients with COVID, the effect of strain actually became much more acute. And so rationing decisions were having dramatic implications regarding who lives and who dies. And the very need to ration in and of itself was exerting a similar effect. One type of proposal that's been put forth to guide the allocation of scarce resources under crisis standards of care starts by eliminating certain types of people. New York State, for example, its approach to managing scarcity was to start out by taking patients with certain diseases or limited life expectancies out of the equation entirely. Those patients would never get critical care if the state had enacted a crisis standard of care. And echoing back to Dr. Lowe's comment that in a reasonable public health ethics framework, one of the criteria is to use the least restrictive approach possible. This simply doesn't pass muster according to that standard. And the reason is it's actually not necessary to eliminate categories of people from eligibility. Instead, it's entirely possible to have everyone remain eligible and have them competing for scarce resources when there is need to do so under widely accepted and disseminated standards. There are a variety of other downsides to categorical exclusions that I will just mention a few. Great potential to exacerbate underlying social inequities because persons with different social advantages or disadvantages may have greater or more advanced stages of illness simply by virtue of their access to care. Could discriminate against persons with disabilities and thus face legal retribution. And I can say that to categorically exclude certain patients from eligibility rather than to keeping everyone eligible and allocating as best one can, is unlikely to assuage the growing pandemic of clinician burnout that we're seeing as a result of the pandemic itself. Here's the crisis standard of care that I developed in the first 3 months of the crisis for our health system. And if this looks complicated, it is. I will say that this is based on the work of Drs. White and Lowe in terms of guiding allocation. And it starts by determining whether a crisis standard of care has been activated. It then sets up a triage review committee that can be that's there for appeals, and then a crisis triage team, trained physicians and nurses whose job it is to apply the agreed upon rules. So it meets those standards of due process by having a legitimate appeals process, and it has experts applying the rules equitably with review of their activities, again, from the triage review committee. I'm not going to walk through all of these points in the algorithm. It is indeed complex, but one of the cornerstones is this model that is based on the work that Drs. White and Lowe have put forth. And this is exactly a snapshot of what Idaho is using today. So in an effort to prioritize saving the most lives and saving the most life years, they give points where fewer points means higher priority. And they divide patients into 4 categories. The highest priority category are patients with a sequential organ failure assessment, or SOFA score, less than 6, meaning their odds of dying in the hospital are relatively low. And then increased points 2, 3, or 4 for higher SOFA scores, meaning their odds of dying in the hospital are higher. And then additional points are added for persons with major comorbid illnesses that have a substantial impact on near-term survival. And even more points are added for the sickest of the sick. So patients with more points have lower priority than patients with fewer points, so as to save the most lives and save the most life years. Seems reasonable. It is reasonable, except like many reasonable systems of allocation, it's got problems. And the problems here reside in the SOFA score. This is work that we put out earlier this year, where if you look at the SOFA categories, 0 being the least sick people, 5 being the upper limit of the highest priority category under the White and Lowe model, and then 6, 7, or 8 or more, you can see that, as expected, whether you're white or you're black, your odds of dying in the hospital go up the higher your SOFA score is, meaning the model sort of does what it's expected to do. It predicts mortality, but it doesn't do so equally. Across every single category, whites with a given SOFA score die more in the hospital than do blacks. So let's think about what the implications of that are.
Dr. Halpern, 5
Yes.
minutes, please. 5
Thank
minutes.
you. The implications are that if you think about everyone with a SOFA score of 5 or fewer being eligible to be in the highest priority category, then 81.6% of patients who have a SOFA score 6 or higher among those who are black would actually have the exact same mortality risk as the patients who are white who are getting the highest priority. That's a huge and unjust effect. And I would argue completely prohibits the ethical use of SOFA scores in crisis standards of care. So just to review, and then get to the positive points. I mentioned that without pandemics, we've got too much critical care. And yet, even so, we do suffer from capacity strain that causes us to allocate. Absent pandemics, we allocate equitably and efficiently. We don't harm patients, and we don't allocate differentially across morally irrelevant distinctions. Well-intended proposals to govern allocation are needed, but the ones that we have at our disposal right now are problematic. And yet there are some lessons that we can learn. This is work from a close colleague, Georgia Nisi, out recently showing the University of Pennsylvania health system's experience in the early weeks of the pandemic, showing that very quickly we learned a lot of lessons and stopped doing things like intubating patients early before they truly needed it. That enabled us to dramatically reduce in-hospital mortality well before the advent of effective pharmacotherapies. And this has dramatic lessons for concepts of organizational resiliency and adaptation. It's been argued also recently that this is a lesson of the pandemic, that the hallmark of all organizational resilience is the flexibility to pivot as new and unexpected challenges arise and to absorb unexpected shocks that can't be avoided even if there had been proper planning. We're going to have situations like this in the future. And so this highlights the need to build resiliency and adaptation within our health systems. And there's a great amount of promising collaboration between operations scientists typically found in schools of business and clinicians to figure out exactly what resilient organizations do and don't do to enable them to flex. I'd also like to highlight, this is a picture from the White Coats for Black Lives march that several colleagues and I organized to Town Hall or City Hall in Philadelphia back in June. I'm that guy in the green scrubs just to the left of center in the picture. What's notable to me about this is that 75% of the people you see work in intensive care units at Penn. The pandemic was so obviously worse for many underrepresented groups in our society. And it was so visible in a daily way to all those working in intensive care units that I think it really galvanized a renewed sense of social justice among clinicians of all professions that I think and hope will remain even well after the pandemic. It also helped produce a lot of learning about how we can maintain family-centered care when there are barriers. We couldn't have visitation the same way we were accustomed to. And so we had to adapt. And these adaptations, honestly, I can't wait until they're less necessary, but they're never going to become unnecessary because there are always situations where family members of sick ICU patients simply can't be at the bedside, either due to their work or they're living at a distance or a variety of other reasons. And we've learned how to use technology more usefully to keep patients, family members, and loved ones engaged. We've learned how to set up video conferencing so that the critical care patients who are able to communicate can stay in touch with their loved ones. And we've learned the importance of daily updates, even if brief, through whatever means necessary. And then finally, I'd like to highlight this. I go back to Dr. Lowe's presentation, that I think we've learned a lot about ways in which typical clinical ethics sometimes fail in the course of a pandemic. And that the lessons learned here could provide the impetus for a greater ascendancy of public health ethics over clinical ethics when the two come into conflict. And that would be for the greater good of the greatest number. Thank you.
Thank you, Dr. Halperin. That was a fascinating presentation. We're going to transition to our questions and answers here. Let me just pull up my chat. All right. Dr. Halperin, this first question is for you. You pointed to the disparity of survivability according to the SOFA scores. Would it be sufficient to modify SOFA scores according to the patient's demographic profile?
Yeah, great question. There are ways that are easy to do and ways that are hard to do that could achieve that goal potentially. We explored some. So one of the reasons that the SOFA score is racially biased is because it includes a measure of renal function, kidney function, that is itself racially biased. There are other reasons that I won't get into. We explored removing creatinine from the SOFA equation and found that the racial bias went down, but was not eliminated. We also explored in this work using other severity of illness scores, in particular, one called the LAPS-2 score, or the Laboratory and Acute Physiology score version 2, that was developed in the Bay Area at Kaiser Permanente, Northern California. That score is less racially biased than SOFA, but also does not fully eliminate the bias. One could think of an alternative, and perhaps this is what the person who asked the question had in mind, of giving a correction factor to those who are Black, rather, where they get a boost in priority of some magnitude. In theory, that could work. In practice, whenever we start allocating on the basis of race or any other morally irrelevant characteristic, I worry that we're opening up a bit of a Pandora's box that is how we ought to practice medicine. So it might solve the problem in the short term, but I worry deeply that it opens up a lot of future problems.
Could I add something to that, if I may, quickly?
Sure, please.
So I want to pick up on Dr. Halperin's point about the risks of explicitly including race and ethnicity as a correction factor for making decisions. That would have a great likelihood of running afoul of the Office of Civil Rights, because race and ethnicity are protected categories. One thing that we and others have suggested is instead using something called the Area Deprivation Index, which measures a lot of variables that are known to be associated with poor medical outcomes. So low levels of education, poor job opportunities, crowded housing, et cetera. That doesn't include, and it's on a neighborhood by neighborhood basis, that does not explicitly include race. So it doesn't have Office of Civil Rights problems, but it does effectively predict health disparities due to social determinants of health. And in California, we've used it for allocating other public health resources. So it's a possibility.
And our next question, I think, goes along with this. How do human cognitive biases like loss aversion affect the way we view scarce resources allocation decisions? Are we more averse to shuttering institutional capability than to open new units, even though the strain on staff or the loss of life years would be the same?
Yeah, absolutely. And that was, one of the focal points of the piece we shared in JAMA that I highlighted on the last slide, that, there is this very human, visceral reaction to try and save a visible life that's endangered. And that is a reaction we want people to have. We want to try and save the endangered life. But in doing so, we often neglect the other endangered lives that could be saved, but just aren't right in front of us. And efforts to build more ICUs and produce more ventilators were designed to avoid us facing that tension. And yet they never really could have done so.
All right. Dr. Lowe, do you want to add anything to that?
No,
All right.
that's thank you.
So, Dr. Halperin, should we start refusing limited ICU resources to people who refuse vaccine and masks? If not, why not? And Dr. Lowe, I would imagine you have a comment with that too.
Yeah, I was certain this question was coming. Bernie, do you want to go first?
Sure. Well, this is being actively discussed and debated. Let me say that first, I want to second Dr. Halperin's attention to the plight of healthcare workers. I mean, healthcare workers, particularly ICU physicians and nurses, respiratory therapists, they're frustrated, they're burnt out. They have worked long hours early on without adequate protective equipment. And now they're actually being reviled by some patients and families. They're being shouted at, they're being physically threatened. It's just really hard to be in that situation and know that a good deal of the surge in the highest hit areas could have been avoided had more people gotten vaccinated. And the new twist now is that unvaccinated patients come in saying there's no way they would get vaccinated, but they're asking for either monoclonal antibodies, which could be an effective treatment for them, but are very expensive. And now there's a shortage of these monoclonal antibodies for people who need them for underlying immunological diseases. So I understand the idea of wanting to do that, but I think it would really change in a very fundamental way how we think of the obligation that doctors and nurses have to patients. I mean, once we start saying that doctors and nurses, either as a group or as individuals, can judge who's worthy of care and who's not, we start to get some very dicey situations. And there are, on a limited scale, examples of when a one-time crisis where there's been a mass shooting, for example, and the gunman and the victims are both brought to the same top-tier emergency room for emergency care, that we give priority based on to need and likelihood of survival with urgent intervention. And sort of whether the shooter or the victim doesn't get taken into account now. So we'd have to really fundamentally change things, and it would need to be done, if we decide to do it, through a much broader process than what's going on now on the blogosphere and in newspapers and the radio. It's a political decision. I think medical and nursing professions as a whole have to weigh in and think it through. It's not something we want to do in response to a singular event.
Yeah, I agree that the answer to the question is probably no, that we should not give differential priority based on vaccination status. But I will say that having been in the ICU just this past week, there are many of my colleagues who I think highly of, who, whether out of just sheer frustration or fatigue or some other very normal human response, feel very differently and feel viscerally that it's wrong to not give priority to those who've made socially responsible decisions. And I'd like to highlight that a commonly used counterpoint among ethicists who believe that we should not consider vaccination status in our allocation decisions is the example of someone who was a motor vehicle accident trauma victim who chose not to wear a seatbelt. And the question arises, well, would we ever consider withholding critical care when it's scarce from someone who chose not to wear a seatbelt when we had other equally sick patients who chose to wear a seatbelt? And I think most clinicians would recognize that it's hard to imagine that we would actually do such a thing. I'd like to offer that I do think there's a distinction between those examples that at least pushes the argument closer toward it being reasonable to consider vaccination status. And that is that the choice not to wear a seatbelt, all things equal, doesn't have direct implications for other people, whereas the choice not to be vaccinated does. And so I am sympathetic to that argument for why vaccination status ought to be considered, but I'm deeply concerned that there are many segments of the population who are victims of false information and false beliefs being spread by their community leaders, their political leaders, or whomever. And that would deprive those otherwise very well-intending individuals from access.
This question goes to both of you. Do either of you have any insight as to why so many health professionals refuse the vaccine?
I wish I had an answer to that question.
Well,
Go ahead.
yeah, I was just going to say that healthcare workers are people just like other people in the community, and just getting a nursing or medical degree doesn't mean that we all think as clearly and as data driven away as Dr. Halpern does. I wrote a paper with a colleague who's an African-American physician in Chicago who spent her career trying to work on the South Side of Chicago among African-Americans on improving diabetes care. And she spent a clinic day talking to each of her patients, all of whom are African-American, about COVID vaccination, because she knew that people trust their doctors more than anyone else. And she said at the end of the day, they had gone through several boxes of tissues, run way over time. And there are a lot of people she hadn't convinced. And some of them were nurses in the hospitals, in University of Chicago Hospital. They have the same suspicions, concerns, mistrust. They hear the same things as other people in the community. So although we'd like to think that healthcare workers are more data-driven, it's not necessarily the case, unfortunately.
All right. This is an interesting question, as they all are. Hospitals often let their lawyers manage the enforcement of the mandates. How should we weigh the risk of legal exposure against the benefits of higher rates of vaccination?
Go ahead, Dr. Law.
Well, lawyers are really important for giving advice and their best judgment as to what the legal consequences of your decision would be. So if you choose to implement a vaccine mandate among your employers, and you know that a lot of people are going to quit and you're going to get lawsuits. What the lawyer can do is say, if you do these things to modify your proposal, you'll be on more solid legal ground. But ultimately, it's a policy choice as to whether the mission of your hospital or other organization is predicated on your having a workforce that doesn't put clients, patients, customers at risk. These should be made by the policymaking board of the company, president, CEO, maybe the board of directors, and the lawyers chime in, but it shouldn't be done. Risk managers should not be the sole people making these decisions, in my own opinion.
Yeah, I agree. And, working at the first university to issue a mandate for all faculty, staff, and trainees. Certainly many others have followed suit since. I can say that there were a lot of there was a lot of money spent on legal counsel before Penn made that decision. And a lot of investigation that I think has proven correct, actually. Certainly the Indiana court decisions have upheld the legality of vaccine mandates in a crisis. And to my knowledge, there haven't been any successful suits to date. That said, even unsuccessful suits carry a real cost, both financial and emotional and reputational for an organization, and that all needs to be considered.
I agree. We're going through some of that right now here in Grand Rapids locally. So as we work through that, Dr. Lowe, do you have anything to add to that?
Well, just one additional comment, and that's that there are a number of states that have state laws that have various kinds of prohibitions on vaccine mandates. So I think it is important to know what the law in your state says and doesn't say. It may prohibit vaccine mandates for certain groups of employers or institutions, but not others. I think also there are hard mandates and soft mandates. So the hardest mandate, and we did this at the University of California, we said, if you want to register for classes, you need to be vaccinated or have a valid medical reason that you're not vaccinated. And we also took into account religious objections, but kept that fairly narrow. I think that that has stood up so far, but the lawsuits are coming. So you need to be informed as to what the legal consequences might be, and then make the best decision you can make.
All right. Let's move on to some of the other questions. Idaho, Alaska, Texas all have crisis standards of care. Do you think more states to have crisis? Do you think more states to have crisis standards of care? And do you have thoughts about why more states have not instituted crisis standards of care?
I can start there. Idaho, Texas, and Alaska have implemented or activated their crisis standards of care. The majority of states, vast majority, perhaps even all, have crisis standards of care. The criteria to activate them may differ, and what those standards are may differ. But I think that's the point to take home. My hope, and I'm sure everyone would agree with this one, this is a very non-controversial statement, is that no further states need to activate their crisis standards of care. And that the 3 that have done so recently will be able to deactivate them soon. But that's the important distinction.
Yeah. Now, if I could just add to that excellent answer, I would just say that you need to have crisis standards of care developed and thought through before they're needed. And unfortunately, as human beings, we're much better at putting things off until we really need them right now. Dr. Halpern's talk pointed out some of the problems with the early state crisis standards of care. And they were put out there, and then there was a lot of discussion, criticisms, and they were modified, I think, for the better. So I think these are ideas that need to be worked out in advance. And also the implementation is super important. The most important thing about crisis standards of care is realizing all the things you need to do so that in an emergency, you don't have to implement them. And a lot of things are like having regional-wide coordination among different hospitals and among different neighboring states. So there are various things you can do short of implementing crisis standards of care, but the crisis standards really hold you to the fire. They say if worse comes to worse, this is what will happen, and none of us want to see that. So let's do all these other things to try and forestall the need for implementation.
Thank you. Dr. Halpern, could you expand on what the organizational or flow chart looks like to activate a crisis standard of care?
Sure. So the activation step is that basically, for Penn, or really for any institution, the governor declares a crisis, a public health crisis. So that is the starting point. So fortunately, Pennsylvania never got there, or Governor Wolf never declared it a public health crisis. But Idaho, Texas, and Alaska have all gotten there. So that's what activates it. And then once activated, the subsequent steps would be put into place. Now, early in the pandemic, we did go through the process of standing up a crisis triage team. I was one of 5 physicians who, had we needed to do this, would have been doing shift work. I would have been removed from ICU duty and instead would have staffed the triage team to calculate acuity scores, comorbidity burdens, and assign priority and direct triage accordingly. And then there was a review team that was also stood up that would have overseen what we were doing and heard appeals from patients or family members. And we all went through, simulated training to get ready to do this. It was awful. It was absolutely terrible. Thankfully, we never had to put that learning into practice because our crisis standards of care were not activated.
We did some of that here too, and I was thankful when we didn't have to activate that, but we prepared ourselves and did simulations, and that was pretty difficult.
Yeah.
Dr. Lowe, do you have something to add there?
I agree completely.
All right. Dr. Halpern, do you think that the great differences of the number of ICU beds between American and European countries has something to do with the lack of universal health care in the US?
How am I going to answer this? So I am sympathetic, very much so, to the lack of healthcare, universal healthcare in the US being a major problem that I wish had been solved by now. That said, looking at the data, I can't make a compelling argument for there being a direct relationship between those two things. And the reason is this. In the US, the average acuity of a patient admitted to the intensive care unit is much lower than it is in, say, the UK. In the UK, 75% of patients in ICUs are mechanically ventilated. And as I showed you, in the US, it's about 33%. That's a big difference. And it reflects a higher bar to entry in a nation with fewer ICU beds per capita. And so if you thought that the causal problem was lack of universal health care, you would presumably be positing that there are more patients who get critically ill per capita, thus driving the need to build more beds. But in fact, I think this is a case of demand-induced supply, not supply supply-induced demand, not demand-induced supply.
Dr. Lowe, do you have anything to add?
No, I agree.
All right, the next question, this brings us back to scarce resources. When we thought ventilators were the scarce resource, we thought we would have to decide if a vent would have to be withdrawn. What will the parallel look like when the scarce resource is staffing?
Well, I can start. I'll just speak from personal experience. So we did stand up more ICUs, and we converted many of the ventilators we used in the OR for use in these expanded ICUs. And as a result, we had enough beds and enough vents for all the patients that we saw during the worst of our surges. It was close on many days, but we did. That said, we didn't have enough trained clinicians. We had hospitalists and cardiologists and even endocrinologists managing critically ill patients with the help of nurses who are not trained in critical care nursing, and with much scarcer respiratory therapist staffing than we would otherwise deem appropriate for staffing ICUs. Now, I will say we have not gone and looked at what the consequences of that were. I honestly don't think anyone really wants to know the answer to that. It was awful for the health system to have to do that. It was more awful to put clinicians who are experts in certain domains into a position where they knew they weren't expert, and yet they were charged with such monumental tasks. I can only imagine the stress and trauma that those clinicians felt.
Yeah, if I could just add to that, Scott, I really feel the pain that you and your colleagues went through, and that was required. You mentioned organizational resiliency in your talk, and this is a good example where some creativity and organizational resiliency needs to be brought into play. Some hospitals devised a new model of giving care so that an expert like Dr. Halpern, rather than providing hands-on care, was put in the position of supervising these physicians who were put in, given responsibilities they weren't trained for. And he was really their consultant, could have been their consultant in a proactive way. Similarly with nurses, you could use your really skilled critical care nurses as sort of the hands-on mentors and answering questions of the nurses that were rushed into unfamiliar situations. A lot of hospitals found that it was really important to think about the mental well-being of their staff who are under stress. And so trying to find ways to give people breaks, give them restrooms where they could, safe spaces where they could decompress, offering counseling, on the job. Those sorts of therapy dogs, anything you can think of, all those sorts of things, I think need to be done, tried, and as Dr. Halpern says, no one doesn't want to try and stretch their clinical capacities, but no one wants to see whether in fact you've made things worse by putting people in way over their heads without the kind of backup that you would like to see.
I agree. I saw our ICU develop some sanity sessions, which made it a safe place to just vent
Mhm.
some of the emotions that our clinicians were going through and going through as a team. Moving on to our next question, we are going back to a little bit about the vaccines. This is for both of you. Should the natural antibodies developed from having COVID not being used as an alternative to the vaccine?
Well, if you contract COVID and recover, your body develops antibodies. And presumably, if you were faced, because you can get reinfected with a second exposure, your immune system would be primed to respond. However, the level of antibodies wanes over time. And what we don't know is if it wanes beyond a certain point and you're challenged with a second exposure, do you respond quickly enough to be able to fight off that second exposure? That's the kind of data we really don't have. So whether people need a booster shot, even though you've had COVID before, it's not feasible to have everybody get COVID antibody levels on a regular basis. And we don't even know, as I said, immunologically, what it means to have a low titer, whether you'll respond if you're exposed to another dose of the antigen.
And I'll just say, just because I'm not sure I fully understood the question, and were we not virtual, we would have had opportunity to try and clarify. But in case the questioner was wondering more about whether something we do use, convalescent plasma, the antibodies from recovered patients, which we have a little bit of data to suggest it's helpful in treating patients who have developed disease. We have no data whatsoever that using that would prevent disease. And probably the reason no one's bothered to study it is because it's a completely infeasible approach. Like, to get enough of that to administer to hundreds of millions of people would produce scarcity, of many, many orders of magnitude beyond what we've been talking about here today.
And so much that we continue to just learn by experience. This question again about vaccines: why ethically should we have religious exemptions for vaccine requirements, but not for requirements to stop at red lights and not drive on the sidewalks, etc.?
Yeah, I've been looking at that question on my screen. It's a great question. Thank you for asking. A two-part answer, if I may. First, in some religions, rejecting medical interventions is a fundamental belief in the religion. So if you think of Christian scientists, for example, who reject medical interventions, I think when it's a well-characterized basic part of one's religion, I think our idea is that we want to respect that, because we believe that respecting people's deeply held beliefs is important. Another example, not on vaccines, but Jehovah's Witnesses' refusal of blood transfusion. They're steadfast. They say they'd rather die than get a blood transfusion. So those are very specific, and they've been worked out in the law and in ethics. Those are organized religions that have a lot of discussion of what one believes in, if you remember that religion. And as religion need not be organized. It need not be a part of a formal church. How do you judge those kinds of beliefs? Now, what's the difference between religious exemptions for vaccine requirements, but not for requirements as a driver to stop at red lights, not drive drunk and so forth? Well, you don't have really a choice to be sick. I mean, I suppose you can put yourself more at risk by some of the things you do that might expose you to COVID. But when you need care, that's a decision that's got to be made on the spot. Driving is considered a privilege and not a right. Well, I guess healthcare in this country is not considered a right either. But you're warned in advance that, you know, if you drive, you can't run red lights, you can't drive in the slash, you can't drive drunk. You have to, that's part of the test you take. So you're put on notice that if you don't agree with that, that's fine, but then you don't get a driver's license. So it's a partial, or at least a start at trying to answer.
All right, Dr. Halperin, do you have anything to add?
No, I agree fully.
This is for both of you. Should we create a consent form that patients can sign to agree being treated by an unvaccinated healthcare provider?
You want to start, Scott?
I'm sorry, so a consent form for where patients would have to agree to be treated by an unvaccinated provider. Huh. I think I'd rather focus my time and effort on making the case for why not putting patients at undue risk is a fundamental obligation of a healthcare provider. And if we could come to agreement on that norm, which I feel strongly about, then I don't think there'd be need for a consent form in these cases.
Yeah, I think that's right. I actually would like to see something on an institutional scale. If you have a choice to go to an emergency room and probably be admitted or cared for, would you want to know what percentage of the medical staff or nursing staff is vaccinated? So to the extent that information can drive a choice, would that be useful? And would that create an incentive for hospitals to compete on getting a high level of compliance with vaccination? Similarly with nursing homes. I mean, you often don't have a choice which nursing home you go to, but families made some really tough decisions to take their loved ones out of a nursing home and bring them home because there were outbreaks. And surely, well, we know, in fact, that one of the drivers behind nursing home outbreaks are staff who are exposed at another nursing home they work in or in their community, bring it into the nursing home and trigger an outbreak.
Exactly. Well, let me check. I'm not seeing any more questions in our Q&A. I think this goes along with it. Should hospitals therefore publish their vaccination rates or the percentage of exemptions that they have granted?
Well, again, my hope would be that the vaccination rates in all hospitals in America would be well above 95%, and that the exemption rates would be low. That said, there are different exemptions that might be put into place. And as Dr. Lowe was suggesting, public dissemination of those data could create competition among hospitals to narrow the exemptions that they will deem acceptable. So just as one example, any organization that implements a mandate has the option of how it adjudicates a medical exemption. The organization can require a physician's note approving of that it's a valid medical exemption, but they don't have to require that. Penn has, and I know of an individual at Penn who has tried with 3 different physicians to get a written notice as to his reasoning for why he won't get vaccinated so that he can maintain his job at Penn. And none of those physicians have deemed it appropriate to provide that medical backing. And he's going to lose his job as a result of it.
Yeah. I agree. How you implement the policy is really important. I think Dr. Halpern was absolutely correct when he said you want to try and persuade as many people as you can. We face that very question at the University of California. What kind of medical exemptions would we allow for not just COVID vaccines, but there are vaccination requirements, registration for lots of other things. We decided that just a letter wasn't enough, that you had to have the doctor complete a checklist as to which of the CDC approved medical exemptions you qualified for. The list of exemptions for the COVID vaccine, at least the mRNA vaccines, is really short. It's probably anaphylaxis that led to a long ICU stay with your previous attempt at vaccinations. UC also keeps track of the doctors who write these notes. And there are doctors who will write lots of notes, scores of notes for people. And you wonder how much individual evaluation is being given if a doctor's written 20 or 50 or 100 notes.
Yes. So this last question, I think goes right along with this. Does an unscrutinized exemption eviscerate the moral underpinnings or institutional authority of a vaccine mandate?
I'm sorry, I didn't quite catch the question.
Does an unscrutinized exemption eviscerate the moral underpinnings or institutional authority of a vaccine mandate?
Let me just say, you'd like to trust that people do the right thing and they follow a well-intentioned and well thought out policy for the good of other people. But I think we also know that some people don't do that. Some people sort of do everything they can to get to do what they want to do without running afoul of policy. So I think, unfortunately, in this day and age, I'm not sure you can assume that people act with thoughtful, noble intentions all the time. That calls for some sort of scrutiny.
Yeah. Comes down to what you believe is the target vaccination rate for an organization and, levels of risk tolerance. It's a challenging issue, to be sure, that different organizations are tackling differently. Some want nothing to do with questioning any claimed exemption, and they'll just let them all pass. And others are scrutinizing them much more heavily and systematically.
Yes, I'm not seeing any more questions. So with that, why don't we conclude? I would like to thank Dr. Lowe and Dr. Halpern for their intriguing presentations tonight and sharing your wisdom and your insights. I trust each of our attendees will find practical ways to apply their learnings to their practice. I would like to thank the Colloquy and the organizing committee for continuing to provide a forum in which physicians and other professionals can engage in conversation with experts in the field and discuss relevant dilemmas, ethical dilemmas they are facing in their daily clinical practice of medicine. I want to thank our sponsors, Grand Valley State University, Spectrum Health, and Mercy Health. Are there any other closing comments that I should cover before we call it a night?
I would just like to add my thanks to you and the organizers and the sponsors of this. I think it was a terrific event. And just want to say it's always a pleasure to be on the program with Dr. Halpern. I always learn a lot and impressed with the high quality, prodigious amount of research that he and his colleagues do. So thank you, Scott, for that.
And I'll just share my thanks to all the organizers. I've learned so much from Dr. Lowe over the years and including tonight. And then I'd also like to thank all of the participants who listened and asked really thoughtful questions, some of which we've clearly thought about before and yet still struggle with, and others of which were completely new. So that makes it much more fun for us. Thank you.
Thank you both for sharing your expertise. It has been a fascinating evening for me. Again, as a moderator, I've appreciated getting to know both of you a little bit better. And I want to thank our audience for your engaging questions and dialogue. It has been a privilege and a pleasure. Thank you all.